My name is Yvonne Matthew. I am the nurse manager in Fort Maine, which is one of our acute care units here at Children's National, and I will be with you today to discuss management of poor breathing mechanisms. So today's objectives will be to recognize early and late signs of respiratory distress and impaired breathing, initiate appropriate oxygen therapy, and identify when it is inadequate, demonstrate proper bag mask ventilation technique, reassess respiratory status, escalate to advanced airway support when needed, and discuss monitoring and safety considerations. Let's start off with two pre-test questions. 1. When a person is not receiving supplemental oxygen, what percentage of oxygen are they breathing in room air? A, 45%, B, 60%, C, 21%, and D, 15%. What do you think? C, 21%. 2. What is the most important factor in delivering effective ventilation with a bad valve mask? A, squeezing the bag as hard as possible. B, ensuring a tight mask seal and open airway. C, increasing oxygen flow above 15 liters per minute. And D, ventilating as fast as possible. B, ensuring a tight mask seal and open airway. So now we're going to go through a slide that's just going to touch base on information that you've already gone through in your last session. This is an overview of breathing mechanics in pediatrics. So normal breathing requires coordination of function with just having an airway that's patent, nothing that's obstructing or blocking your airway. You have lung compliance, just that ease of being able to breathe in and out with no issues. Respiratory muscles, we're looking at your diaphragm as well as your intercostal muscles. Those muscles are working properly and they're letting you to use those muscles so you can breathe in and breathe out. And then neurological control. So your brain is telling your body, oh, it's time to take a deep breath in, time to take a deep breath out. And you're doing this even without thinking about it. So the difference with just normal versus like children, it's here in the side of the screen. With children, we find that they have a smaller airway diameter. So it can easily be obstructed. It can easily be blocked off when they're eating food and they don't swallow correctly. Something can get stuck in their throat and blocks their airway. Flexible chest walls, they're less efficient lung expansion than compared to like when you're an adult, as well as they require increased energy demand. And with increased energy demand, that means that they need increased oxygen demand. And then as far as children, they do have immature immune response, so they're more prone, more likely to get an infection. And so they're at risk of infections as well. So this is the pediatric respiratory assessment framework. This is basically what I typically use to evaluate a pediatric patient's clinical signs and symptoms. It helps me determine the severity of the respiratory distress, to identify a type of respiratory illness, and give me the guide to, diagnose and treat. So what we're looking at with the triangle here is the patient's appearance, their work of breathing, and circulation. As far as appearance, we want to see the level of consciousness. Are they awake? Are they easily alert to touch? Ability to speak. Are they having an easy time to talk to you? Or do you find that they're gasping for air in between words? Work of breathing, what are we looking at? We're looking at their respiratory rate. Is that respiratory rate within normal of what it should be for their age group? Are we looking at them breathing a lot faster than normal? So that would make them tachypnic. We're looking at accessory muscles. Are they retracting using their subcostal muscles? Are they head bobbing, and grunting. And then circulation, you want to listen to their breath sounds. Do they have any air moving through their lungs? And if not, that's concerning. But also you're looking at their oxygenation. Where are their levels for oxygenation? Are they below 90%, or are they higher than 90%, which is a great sign on room air? And then what the color, are they pale? Are they turning blue, which we don't want? Those are the things that we're looking at when we talk about appearance, worker breathing, and circulation. So I put this slide in here just to kind of give us a baseline of what pediatric respiratory ranges look like. I've divided it up in age groups, the normal range of what you should expect within that age group, and then from mild, moderate tachypnea to more severe rapid breathing. Just a quick overview, as a refresher. Now, what are the main causes of acute respiratory failure in children? And I know this was covered in the last session. Just the big categories, we're looking at upper airway obstruction, anaphylaxis, or it can be some type of infection that can cause upper airway obstruction. We're looking at the lower airway obstruction as well. Could it be bronchiolitis, asthma that can be causing the lower airway obstruction? We also have restrictive lung disease that can be affected by someone who has pneumonia. The central nervous system, there's diseases in the system where it could be, or even just trauma itself, head injury, that can lead to poor breathing mechanisms. And then we have the peripheral nervous system and muscle disorders as well. Looking at muscle dystrophy, where someone who is diagnosed with that at an early age can progressively have weakened muscles as they age, which could mean that they're more susceptible or more likely to have respiratory issues later in life, or if they were to have a respiratory virus, that they may have more of a complicated respiratory distress compared to a healthy child. And then I also added this slide of clinical presentation of major causes of acute respiratory failure, just to kind of give you an overview what to look for depending on what the patient presents with. If a patient has a history asthma, we're looking to, hear wheezing, listening to breath sounds. Sometimes it's more audible. Sometimes you have to use your stethoscope to listen to hear the inspiratory, expiratory wheeze. They could also have diminished lung sounds as well. Complain of chest pain, chest tightness, have like a cough as well, and that they're also showing increased worker breathing through like their accessory muscles. Again, another one is pneumonia. A patient can come in with increased worker breathing, they're tachypnic, as well as having a fever because they have an infectious source that's causing that fever, and just having a difficult time breathing. They can have, let's say, cough, a runny nose, all the things that come with someone that may have pneumonia. So this is just a brief overview that I wanted to share and kind of quickly touch on. Now, clinical consequences without intervention. We would find that our patients would have low oxygenation, hypoxemia, so low oxygen in the blood. We would find that they would have high carbon dioxide. Another term for that would be hypercapnia. Acid buildup in the blood, respiratory acidosis. And then we would have increased worker breathing, which would eventually lead to fatigue, severe respiratory failure, and then eventually cardiac arrest. So oxygen saturation, what is it? This is the percentage of hemoglobin in the blood that is carrying oxygen. We use a non-invasive device called a pulse oximeter that measures this for us, and so it helps us determine how much oxygen is flowing in the patient's body, in their blood. Commonly placed in the fingertip, not in the fingertip, but on the fingertip, which is, I find, the most accurate. But you can also place it on the patient's toe, their earlobe, their forehead, which requires specialized sensor. Normal ranges are between 95% to 100% of their oxygen saturation. Anything below 90% would be of concern and would need intervention and would require immediate medical attention. But you also need to know the past medical history of your patient, because some patients who have lung conditions or any medical conditions that affect their lungs or their heart may need to have a saturation level of 90 or less than 90. And so you need to pay close attention to that, and just be reminded that even though we have this lovely device that gives us levels and readings that we rely on to determine next steps in our patients' clinical interventions, we also need to be aware that it can provide false readings. So we need to make sure that, if a patient's hands are cold, you can get a false reading. If they have poor circulation. Another big thing that I've seen often in practice, especially with the infants and toddlers, if they move around a lot, they kick, they're crying, you're not going to get a good reading, and you're going to get false numbers. So something to take into consideration. And as always, being a clinician, you always have to use your clinical judgment, making sure that whatever is showing up on the monitor, does that match what you're seeing with the patient, and taking the necessary steps to ensure that you're providing good care to your patient and escalating care as needed. These are the types of pulse oximeters that you can find. This one right here, the top left corner, is the one that we use in the hospital. This gray part over here is what we connect to the cord that's connected to the monitor, and we're able to visualize the patient's oxygenation levels once they're connected to the monitor. In other places, you'll have a smaller device that you can just place on the finger. I've put a picture here of the kid who has the pulse ox on their forehead and then on their earlobe. You can also place it on their toe, like I said. But the big thing is making sure you put it on right as well. If you're putting it on the finger, you want to make sure it's nicely secured on their fingernail and not on the tip of their fingernail, because it's not going to read correctly. And I did provide a video here for us to watch. So I'm going to go ahead and let you watch that video, and we'll get back to the presentation. So now we're going to talk about an oxygen cylinder. What is it? It is a metal cylinder that is filled with a set volume of compressed oxygen and can deliver oxygen at a concentration of up to 99.5%. It's used for patients who are in respiratory distress, patients whose oxygen levels are less than 90%, as well as those who have certain medical conditions that require them to be on oxygen. Before the oxygen reaches the patient, it passes through a flow regulator to ensure delivery. The delivery is prescribed based on the patient's needs. So obviously you would need an order, and the doctor's order would tell you how much oxygen you need to provide the patient. It should be refilled when the pressure gauge reaches below 25% capacity. And then you always want to keep it upright and secure to prevent injury, leaks, or equipment malfunction. So there's multiple parts to the oxygen cylinder that I'm going to go more into detail about. There's two main parts. There's the cylinder, that's the bigger portion of the tank itself, or the cylinder. And then you have the gauge and the flow meter. When we talk about the gauge is where you look at to determine how much oxygen is remaining in the cylinder. So when you get to about 25% or less, that's when you would need to make sure that it gets refilled with more oxygen. As far as the flow meter, it's right here, this black knob at the tip. Here you can see the number 1. This is telling us that the patient is currently getting a liter of oxygen. So you can always use this to increase or decrease the flow, the oxygen flow. You can go up to 2 liters if you feel the patient needs it, or you find that the patient is doing a lot better and has improved with their breathing and their tachypnea, then you can lower their oxygen as you try to wean them down to room air. Now, you always want to make sure that you have infection prevention as part of your process when caring for your patients, including with the oxygen cylinders. You want to make sure that you perform hand hygiene before and after use. You always want to wear PPE as well before handling oxygen cylinders, as well as ensuring that the cylinders are clean in between patients. So once it's used in the patient's room, making sure you clean it before it is used for another patient. And then if you're using the cylinders for an extended period of time for a patient, you want to make sure that the humidifier that you're using, which is right here in this picture, is just an example. There's different ones out there. But if you're using the cylinder, you want to replace the sterilized water in this container every 2 to 3 days as far as part of infection control. Now, as far as medication safety, we all know that, or at least we should know that, oxygen is considered a medication, and we must be very careful when we administer oxygen to our patients because it can be harmful. We also want to make sure that when we're administering oxygen that we are following the provider's orders and making sure that whatever is ordered for this patient is what we are administering. As far as patients who require nebulizer medications, like an asthmatic who's wheezing, who requires albuterol, that helps to relax the airway muscles and improve breathing, we should take that into consideration, but making sure that it's based on the patient's diagnosis. And then finally, we want to monitor the patients for signs of oxygen toxicity. When administering prolonged or high concentration oxygen to prevent cellular and organ damage. Side effects of oxygen could include headache, nausea, vomiting, chest pain, and blurred vision. If your patients start to complain about any of these side effects, start to think about whether the oxygen is causing harm. Now, let's talk more about oxygen therapy. Like, when and at what point would we want to escalate care in pediatrics? So here's some indications, just a short list, but there could be others out there as well. For indications, we would be concerned or should be concerned for increased worker breathing. So let's say we've tried to initiate some measures to help with their worker breathing and it's not helping. If you notice that the patient has continued to have worker breathing or has increased worker breathing, then we would want to escalate care. If they continue to be tachypnic, so they are an infant, and we know with infants that they can breathe up to 60, which is somewhat normal for them, but we're finding that they're breathing to the 70s and 80s, and they've continued to do so, then we would want to escalate care. If they're nasal flaring, if they're grunting, you'd see that more so with the smaller kids. If their oxygen levels keep dropping below 90%, would be concerning as well. And that's despite your current support or measures that you've already put in place, and they're still having low oxygenation levels. increased need for oxygen. So you may have put them on like 0.5 liters or 1 liter of oxygen using a nasal cannula, but you're finding that the patient is requiring more. You'd want to escalate care. If you notice that the patient was alert, probably playful, and then all of a sudden it has increased sleeping, or they're old enough and they sound like all of a sudden they're confused. If they're breathing and then they stop breathing for just a short duration, just breathing pauses is what I call it. It would be of concern and need to escalate care. And then with poor perfusion and with fatigue as well, you'd want to escalate care. So we're going to talk about the different oxygen therapy devices that we use to escalate care when necessary. And then this is like a quick overview of steps of escalation with oxygen therapy devices. So typically our patients, when they come into the hospital, they'll be on room air, 21% room air. But then you would want to kind of follow these guidelines, but you may not necessarily go through the exact same steps depending on the severity of their respiratory distress. But typically from room air, you would go from nasal cannula, simple mask, non-rebreather, high flow nasal cannula, CPAP, BiPAP, bag valve mask, and for emergency support, and then intubation and mechanical ventilation. So we're going to stop at the bag valve mask for this presentation. Okay, so nasal cannula. This is a thin, soft tube with small prongs that sits just inside the child's nostrils to deliver oxygen. Oxygen can be delivered with humidification of up to max of 6 liters per minute. You have to be mindful of the age group of how much you're going to deliver. For like neonates, newborns, 0.5 to a liter. Infants, toddlers, I would say 1 to 2 liters. And older children, 1 to 4 liters. Typically on our acute care floors, we would not necessarily go up to 6 liters. And if we did, it would have to be very emergent and in a situation where we know that the patient is going to be transferred to the ICU. We commonly use nasal cannulas for mild breathing distress and supportive care. It allows the child to speak, eat. It's not as invasive to their face, so they're able to still do things even though they're not too happy to have something sticking just in their nose. But it's better than having something that's more invasive and covers most of their face. And then for the nursing perspective, you just want to make sure that the prongs are in place, they're not displaced, and they're not causing any irritation or skin breakdown. Now, simple oxygen face mask fits over the nose and mouth and held in place by an elastic band. That's it right there. And it delivers 40 to 6% of the oxygen at a flow rate of 5 to 8 liters per minute. We typically use these for a short-term oxygen support when higher oxygen delivery is needed. And again, you just want to monitor to make sure that the mask is on properly and that the patient is tolerating it well. I will say for our smaller children, the toddlers, the school age, don't typically handle this very well. And so we typically try our best to keep it on or have a parent support us when we need to have them wear this type of mask. But we also want to make sure that we're checking for skin breakdown because it can cause skin irritation, and ensure that they're getting adequate oxygen and that we're monitoring their vitals and their levels are appropriate as far as their oxygenation levels and their work of breathing as well. So now we're going to talk about the non-rebreather mask. This one's different from the simple mask, as this one has a reservoir bag that fills with oxygen and uses one-way valves to prevent a patient from rebreathing carbon dioxide. It does deliver 60 to 90% of oxygen with a flow rate of 10 to 15 liters per minute. As a clinician, you want to make sure all valves and rubber parts are intact and working correctly to prevent CO2 buildup in the patient. And you also want to make sure that the reservoir bag fills with the oxygen, and that's how you know it's working properly. Now, with the Venturi mask, it provides precise oxygen concentrations through color-coded valves and is used when careful titration of oxygen is needed. So this is really good for a patient that requires a certain amount of oxygen concentration, and you can be able to precisely track that with the valve that you use. So it can deliver 24 to 60% of oxygen with a flow rate of 4 to 15 liters per minute. And in this photo here, you can see like blue, white, orange, yellow, red, and green. So each valve that you use has a certain percentage of oxygen concentration it'll deliver. And in this photo at the bottom, you see that it's green. This is a green valve. So in the photo up here, green is associated with 60%. So the next device is a high flow nasal cannula. It looks like a regular nasal cannula, but delivers warm, humidified air at a higher flow rate, 20 to 30 liters per minute, and it works harder to support the child's breathing. The level of oxygen can be adjusted from 21% to 100%. Its fast and steady flow of air helps keep the airways open and makes breathing easier for the patient. It's often used for conditions like bronchiolitis. I've seen it used for patients who have asthma, pneumonia, and with monitoring as the clinician or the nurse, the provider, you want to make sure that the patient's breathing status has improved. They're not working as much to breathe. They look more comfortable. They're more alert. They're not as tachypnic as they were prior to starting them on a high flow nasal cannula. You want to also look at their pulse ox, their oxygenation levels, that they're above 90% as part of your assessment while the patient's on high flow nasal cannula. Now, with the continuous positive airway pressure, we call it CPAP, this device provides a continuous steady flow of air through a mask worn over the nose or mouth to keep the airways open. It helps a child or children who are having trouble breathing due to conditions such as sleep apnea, pneumonia, and asthma, or those who have weakened breathing muscles, and improves oxygen levels and reduces the work of breathing when all other measures have not worked. The bilevel positive airway pressure, we call this the BiPAP, functions like the CPAP, but this is slightly different as far as how it delivers the pressurized air. You have higher pressure when the child breathes in, and then you have lower pressure when the child breathes out. It kind of goes in the rhythm of them inhaling and exhaling, and it makes breathing easier. So now we're going to talk about the bag valve mask ventilation. It is a handheld device used in emergency situations for patients who are in respiratory failure or have gone into cardiac arrest. The device can deliver 100% oxygen with a flow rate of 15 liters per minute. It's connected to oxygen supply to increase oxygen concentration per breath. You would want to squeeze the bag once every 3 seconds to provide adequate oxygen delivery. And you want to also make sure that when you're doing this, you have a good mask seal to prevent air leaks, and you want to make sure you're using the right size mask for the age group of that patient. Preferably, this would be a 2-person technique to get the best ventilation for your patient. And then you want to be mindful that when you're giving those breaths, that you're not going too fast, giving those breaths too fast, to ensure that you see the chest rise, you see the chest come back down, and also to avoid the risk of air trapping in the patient's belly. So these are just pictures that I put together on this slide for BVN and different sizes. So to the right, you see that the bags come in different sizes: infant, pediatric, and adult. And then you see the different parts of the bag. To the left, you have this attachment piece here is where the mask will go, as you can see in this other photo to your right. Then you have this tubing here that's attached to the bag. This is where you will connect your oxygen supply to ensure that the reservoir gets filled on this little bag at the end with oxygen. And then the big part of this is just the bag. This is where your hand will go and how you what you would use to squeeze air into the patient. So let's talk about the step-by-step instructions. We kind of briefly went over it just now, but we can go step by step. So to prepare, you want to check the mask size, bag function, oxygen tubing, making sure that all is well and it's functioning properly. You want to connect that bag to oxygen and making sure that the reservoir bag fills up with air. You want to position the patient on their back and flat on their back, and you want to open up their airway. So there's 2 things you can do here. You can head tilt and chin up, or you can do a jaw thrust if there's concern for a spinal injury. You're going to place the mask over the nose, round it over the chin, and then you want to use this technique, this seal mask EC. So for the C, you want to place your thumb and index on the mask top, and the E, your other fingers lift the jaw along the jawline. You want to deliver breaths 1 second squeeze, and you want to see chest rise. And on average, the adults should have 10 to 12 breaths per minute, and then children 20 to 30 breaths per minute. And as you continue to provide oxygen to the patient, you just want to continue to monitor for the chest rise. You want to adjust the bag and airway as needed to ensure that you're providing adequate ventilation. And here's a video for us to watch on more of what this looks like in an emergency situation. Now, nursing considerations. You want to monitor for continued signs of respiratory distress, level of consciousness. Are they alert? Are they not getting confused? Retractions. Are they having more worker breathing, or are they getting better and having less worker breathing because the oxygen support that you've provided is actually working for them? You want to also continue monitoring tachypnea, grunting, and listen to their breath sounds. The other thing is that you want to check that the oxygen delivery device fits correctly, tubing is free of kinks, flow rates are accurately set. You want to assess the patient's skin, ensuring that there's no skin breakdown on the cheeks, behind the ears, and nostrils, and use padding when necessary. Another idea is to use nasal suctioning to help clear the airway. A lot of times patients, especially our infants, are really, we say, junky. They just have a lot of nasal secretions that can block the oxygen from going in. So suctioning is a really good nursing intervention to clear that airway to ensure that the oxygen can flow in with no complications. You also want to make sure we're using humidification. We don't want to dry our patient out through the nasal passages and the mucous membranes. You want to give them that extra moisture that will also add to their comfort when they're receiving oxygen therapy. And be mindful not to use petroleum-based or oil-based products like Vaseline, lip balms, because those can pose as fire risks when we're using oxygen. And again, you want to continue to monitor your patients for oxygen toxicity. So if they start complaining of headache, chest pain, blurred vision, keep that in mind that it could be the oxygen that's now causing a side effect for your patient. And one of the big things that we like to say here, if it's not documented, it's not done. So you always want to make sure any intervention that you've implemented, you want to make sure that you've documented that intervention. So again, you want to look at the date and time you started the oxygen therapy. You want to document the oxygen therapy that's being used. Is it nasal cannula? Is it high flow? You want to make sure that you're documenting your vitals, including respiratory rate and oxygenation levels. You want to make sure that you've documented your FiO2. So we're at 21% or we're at 30%, and the flow rate as well. Are we at 10 liters or are we at 15 liters per minute? And another thing is you want to assess your patient and also reassess. You want to document after initiating the nasal cannula. You want to do a reassessment of how they're working. You want a reassessment of their respiratory rate, their retractions to show if there's any improvement in how they're breathing. And again, provider communication. So if there's any communication between you and the doctor, you want to make sure that's documented as well to ensure that if anyone was to look at your documentation, they would understand what has transpired between your communication with the provider and why care was escalated and how that was handled. So now we're going to get into the case study. We have a patient, a 2-year-old male, who's come to the emergency room with difficulty breathing. As far as history of illness, the child has had nasal congestion, mild cough, low-grade fever for the past 3 days. Today, the parents noticed increased work of breathing. The patient or child has had rapid breathing and has had an occasional wheeze. There's no history of choking or known foreign body aspiration. So that means they didn't swallow any little like battery or any little item that they could have swallowed that could have caused their airway to be blocked. But they do know that the patient or child has had a decreased appetite, so not eating, possibly not drinking as much, and they seem more irritable than usual. There's no major past medical history. He was born at full term, uncomplicated delivery, so there's no concerns when the patient was being born. There's no chronic illnesses. The patient is up to date with his vaccines, and there's no history of asthma or previous hospitalizations. Occasionally, parents say that they give Tylenol for a fever. Patient does not have any allergies, and there's no history of asthma or cystic fibrosis in the family. As far as social history, the child attends daycare, lives at home with parents and older sibling. So now we're going to get into our focus system assessment. General, the patient's alert but irritable. Vitals, looks like the patient has a fever, 101.4, which is 38.5 degrees Celsius. Their heart rate's 140. They're breathing into the 40s, so they're tachypnic slightly, looks like, and then their oxygen levels are 91% on room air. The arterial blood gases, so his pH is 6.5, CO2 is 55, and CO3 is 22. And then nasal congestion, That's kind of mainly it. As far as respiratory status, they are increased. They have intercostal and subcostal retractions. They are doing some nasal flaring, and they're hearing some inspiratory wheeze and crackles at the lung bases and some mild grunting. So we also want to focus on, blood gases. What is that telling us? So now we're going to break up into groups, okay? So as the patient has still having mild to moderate trouble breathing, this is likely due to a viral infection. And now we're concerned that, their respiratory status could get worse. You as a nurse, what would you do as far as a plan of care to ensure that we intervene before his symptoms get worse?